I'm Joe Graydon.
I'm Terry Graydon. The People's Pharmacy podcast is brought to you in part by Squatty Potty, the original toilet step stool that creates healthy toilet posture. Learn how squatting relaxes the colon and allows for easy, healthy elimination at squattypotty.com.
And by Comfy, makers of all-natural buckwheat hull pillows. Comfy pillows provide superior support by conforming to your head and neck for healthy, restful sleep. On the web at comfycomfy.com. For 10% off your first order, enter the code PEOPLES at checkout. Hypothyroidism affects millions of Americans, but the treatment for this hormonal insufficiency remains surprisingly controversial. This is the People's Pharmacy with Terry and Joe Graydon.
Synthroid, or levothyroxine, is one of the most frequently prescribed drugs in the country. Is it always the best treatment for hypothyroidism?
We talk with thyroid patient advocate Mary Showman about why many people are unhappy about their thyroid management. We also talk with a researcher who's found the genetic differences that may help explain why some people respond better to a combination of T3 and T4. How will this discovery affect the way doctors treat people with sluggish thyroids?
Coming up on the People's Pharmacy, new approaches to treating hypothyroidism.
First, the news.
In the People's Pharmacy Health Headlines, a digital temple thermometer distributed by BestMed is being recalled by the manufacturer. According to the FDA, some of these thermometers display temperatures that are inaccurate and lower than actual body temperatures. This might cause the user or caregiver to underestimate the severity of an infection and delay seeking appropriate care. This could be especially serious for children who have a very high fever that might lead to seizures, or for people with compromised immune systems, such as cancer patients. Some retailers that sell the device under their label include Kroger, Meijer, Safeway, Best Choice, BestMed, and Target. The FDA cautions consumers who have a digital temple thermometer to immediately stop using the device. They can return the thermometer to BestMed for a free replacement. These handheld thermometers can be identified by the DDT logo above the small digital screen.
If you have seen a doctor in the last several years, the chances are good that he or she has entered your data into a computer during the visit. Electronic health records have become ubiquitous in healthcare settings, whether at a clinic, a doctor's private office, or in a hospital. They were supposed to add efficiency to the doctor-patient interaction by allowing healthcare providers to access lab results, track patient progress, prescribe medicines, and refer patients to other members of the healthcare team. A new study suggests that there are some serious complications that were not foreseen by the computer gurus who designed these systems. Investigators from the University of California at San Francisco analyzed data from patient-doctor interactions between 2011 and 2013. These were designated safety net clinics because patients often had limited health literacy. They suffered from heart failure, rheumatoid arthritis, and type 2 diabetes. Each appointment was videotaped, and patients were contacted after the visit to assess satisfaction with the interaction. Doctors who spent less time typing on the computer scored much higher in patient satisfaction, achieving excellent care ratings 80% of the time. Doctors who were deemed high computer users achieved an excellent rating less than half the time. The researchers noted that high computer use by a clinician was linked to a lower patient satisfaction and less rapport between patients and physicians.
For decades, a mainstay in the treatment of attention deficit hyperactivity disorder, or ADHD, has been the stimulant drug Ritalin. It's also sold under the generic name methylphenidate. Now, a new analysis of 185 randomized controlled trials by the highly regarded independent Cochrane Review concludes that the evidence of benefit for children with ADHD is poor. According to one of the key authors of the report, our expectations of this treatment are probably greater than they should be. The investigators noted that most trials were small and of low quality. Treatment generally lasted an average of 75 days, making it impossible to assess the long-term effects of methylphenidate. Side effects included sleeping problems and decreased appetite. The authors call for large clinical trials of non-drug treatments for ADHD.
Stimulant medications like methylphenidate appear to interfere with children's ability to get a good night's sleep. Researchers analyzed data from 9 ADHD studies that also objectively measured sleep outcomes. They found that stimulant drugs make it harder for children to fall asleep, interfere with the total time of sleep, and impact sleep efficiency. The authors encourage pediatricians to carefully monitor sleep problems and adjust treatment to promote optimal sleep and minimize medication-induced sleep impairments.
Doctors frequently prescribe acetaminophen to children who develop a fever more than 100 degrees Fahrenheit while they're in an intensive care unit. The thought is by lowering their temperature, such patients will recover faster. Australian and New Zealand physicians tested this theory. They randomly assigned 700 hospitalized ICU pediatric patients with a fever to receive acetaminophen or a placebo every 6 hours. At the end of a month, there was no difference between the acetaminophen group and the placebo group in terms of ICU, length of stay, or other significant outcomes. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. More than 16 million people take thyroid medicine for a sluggish thyroid. Hypothyroidism may be one of the most common conditions in America.
But the treatment for this metabolic disorder is surprisingly controversial. Mary Showman has been a patient advocate and activist for thyroid and hormonal health since 1997, when she became the thyroid expert for the About.com website. She's author of 13 books on thyroid health, hormones, and weight loss, including The Thyroid Diet Revolution and Living Well with Hypothyroidism.
Welcome to the People's Pharmacy, Mary Showman.
Thank you. I'm very happy to be here with you.
Well, we're so happy to have you back. You are one of the gurus of thyroid from a patient's perspective because you've walked this path for quite a long time. Why don't we start at the beginning? Tell us, what are the symptoms of hypothyroidism, which is the most common cause of people's discomfort?
Absolutely. Well, hypothyroidism, for those who don't know what the term means, is an underactive thyroid gland. And your thyroid is a small, usually about an ounce size gland located in the neck. It's shaped a bit like a butterfly, and it's located below and behind the Adam's apple area in the neck. And this is our master gland of metabolism, and it produces the hormones that deliver oxygen and energy to every cell, tissue, organ, and gland in the body. So it is an absolutely fundamental organ. Even if it's overlooked a lot, it really has a very crucial function, and we can't live without our thyroid or without the hormone that the thyroid produces. When the thyroid slows down or becomes hypothyroid, what happens is all of the body processes can slow down. Not necessarily all of them in everyone, but what we see are different types of signs of slowdown. Everything from slower thinking, memory problems, to depressed mood or feeling unmotivated. We also see slowdown in metabolism, so people can gain weight without a change in diet or exercise, or they may be on a great diet and exercise plan and they're not losing weight or even gaining on that. People also find that they're very fatigued. They may need more sleep than usual and feel less refreshed or need a nap to get through the afternoon or to get through the weekend. People also will complain about feeling cold. Body temperature will drop. We see edema or swelling, which can occur in the hands and the feet, or the forearms or the legs, which can also then contribute to carpal tunnel and tarsal tunnel and plantar fasciitis. People will have a slowdown in their follicles development, so they may have hair loss. They, especially for women in particular, loss of the outer edge of the eyebrow is a classic hypothyroid sign. Menstrual irregularities, infertility, low sex drive. So essentially, almost anything that requires energy in the body can be slowed down with hypothyroidism. Another common but not often talked about symptom is constipation, high cholesterol, because the liver isn't working as fast to clear toxins out of the body and to clear cholesterol, so we can have high cholesterol, elevated blood sugar. So really there are so many different symptoms, and unfortunately they are so broad that they're often overlooked as signs of, well, you're just getting older, or you're not getting enough exercise, you're eating too much, get off the couch, take an antidepressant, you just had a baby, you're in menopause. All of these different other life cycle and hormonal issues are often blamed for what are oftentimes very classic signs of an underactive thyroid.
You know, I can always tell when Terry's thyroid supplement isn't quite at the right dose. Her eyes get puffy.
Yes, the puffiness in the eyes and under the eyes and above the eyes. Some people even have it in the face. Is also a common symptom. Some people also notice puffiness and swelling in their feet and hands as well.
And the reason that Joe says, well, my dose may not be quite right, is because I actually do something a little unusual and probably not approved by the majority of endocrinologists. I adjust my dose throughout the year because I find I need less thyroid hormone in the summertime than I do in the wintertime.
Well, there are actually studies that point to that necessity, because part of the thyroid hormone's function is to help regulate body temperature. So when the temperature is colder, the body has to work harder to stay warm, and the thyroid plays a role in that. And so some very forward-thinking doctors actually test people as we head into the winter months and into the spring months to do that adjustment. And for some patients who've seen that happen year after year, their doctors actually say, look, the minute it starts to get a certain temperature, I want you to bump your dose up or down appropriately, and they give the patient the latitude to go ahead and do that on their own, because they know that some people, not everyone, but some people definitely need more thyroid hormone when the temperatures are colder.
And my doctor and I have that kind of agreement.
That's wonderful.
Mary, how is hypothyroidism diagnosed? You mentioned that these symptoms can be somewhat nonspecific.
Yes. The diagnosis of hypothyroidism, it depends on who you ask, because if you ask a conventional endocrinologist or a general practitioner who's not all that interested in the intricacies of thyroid disease, typically what they're going to do is run a test called the thyroid stimulating hormone test, or TSH for short. And this is, according to the conventional medical world, the gold standard for identifying a thyroid problem. And the TSH is actually a hormone produced by the pituitary gland, and it's essentially a messenger hormone. So when the thyroid is not doing its job and putting out enough hormone, the brain, the pituitary, releases more TSH to tell the thyroid, make more hormone, make more hormone. Conversely, it drops down when we have too much thyroid hormone. So they measure this secondary hormone that's produced by the brain as a way to gauge what's going on with the thyroid. The standard range, it depends on which lab you go to, but it runs from about 0.5 to about 4.0, 4.5. Sometimes it's 5.0. It depends on the lab. But the top end of the range is considered the mark-off point for hypothyroidism. So levels above that are considered subclinical or borderline hypothyroid, and levels above 10 on the TSH are considered to be evidence of full hypothyroidism. But again, this is the conventional view.
Mary, this is very controversial stuff because the guidelines, the normal levels have changed pretty dramatically over the last couple of decades. And people don't always understand that the higher the TSH levels, the worse the thyroid function is. So could you explain this controversy and how people can better understand this TSH story?
Yes. The issue with TSH is, again, because it's a messenger hormone, it operates in a converse or opposite relationship to the thyroid function itself. So the worse the thyroid is performing at its job of producing hormone, the more TSH goes up. So the slower your thyroid gets, the higher that TSH goes. the problem is that we've had a lot of back and forth, even within the conventional medical community, as to what that normal range really should be. Because what a lot of research has found is that the vast majority of the population of people who have no thyroid issues at all and no autoimmune disease that's affecting their thyroid have a TSH less than 2.0. But when they run these lab ranges, the lab ranges are taking a cross-section of the broad population, including people who have some mild thyroid problem or who have a developing thyroid issue or autoimmunity. So that is why the range tends to be much broader. So there was a period a number of years ago when the endocrinology community said, wait, the range is too broad, we're going to go to a narrower range, and they were saying that they were going to put the cutoff at 3.0. But the laboratories never adopted that because it wasn't an official recommendation. The lab stayed at the top end of 4.5 or 5.0 or even as high as 6. Then the endocrinologists have sort of backed away from that again and gone back to the older, broader range. The challenge there is that even within endocrinologists, some still believe that the lower number reflects a better functioning thyroid, some don't. So you can have a TSH of 4.9 and go to endocrinologist A, who will say your thyroid is fine, you don't have a problem. You can go across the hall at the medical building to endocrinologist B, who would say you're subclinically hypothyroid, I'm going to put you on treatment. So for a gold standard test, they don't even agree amongst themselves as to exactly where the cutoff points are from a diagnostic or therapeutic standpoint. But then the additional issue is that with the interest in thyroid and an increasing focus for a lot of the holistic and integrative practitioners who are doing a lot of work with hormone balance and immune system function and all of the different elements that go into good health and hormone balance, they are very, very adamant about not just relying on the TSH test alone as an arbiter of thyroid diagnosis. They want to see the actual circulating thyroid hormones. And the two key hormones that the gland produces are T4 and T3. So a lot of practitioners say, look, a TSH tells us what the pituitary is doing, but we want to see what's actually circulating in your bloodstream. And so they will order free T4 and free T3 tests to look for the available amounts of T4 and T3 circulating in your bloodstream. There's another subset of the population that has elevated thyroid antibodies, thyroid peroxidase antibodies, which is evidence of an autoimmune attack that slows down the thyroid. You can have normal thyroid blood tests for TSH, free T4 and free T3, but still have symptoms, and in that case, treatment can prevent progression to full hypothyroidism and can lower the antibodies.
You're listening to Mary Showman. She's a patient advocate and activist for thyroid and hormonal health. Mary has been the thyroid expert for About.com since 1997. She's written 13 books about hormones and thyroid health, including The Thyroid Diet Revolution.
After the break, we'll find out what target numbers you might look for in your lab results. The standard treatment for hypothyroidism uses T4 alone. What role should T3 and iodine play? Are there people who have trouble converting T4 to T3? And what natural approaches can people use to treat hypothyroidism? We'll also learn about new ways to treat low thyroid, including low-dose naltrexone.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number is 800-345-7339. The The website is uddercream.com.
And by Squatty Potty, the original toilet footstool that creates healthy toilet posture. You can learn how squatting relaxes the colon and allows for easier, healthier elimination at squattypotty.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show is number 1015. That number again, 800-732-2334, online at peoplespharmacy.com.
Today on the People's Pharmacy, we're considering the latest research on hypothyroidism and how it can be treated. Our guest is patient advocate Mary Showman, herself a thyroid patient and thyroid expert for About.com. Her books include Living Well with Hypothyroidism and The Thyroid Diet Revolution.
Mary, if a patient were to go to a progressive endocrinologist, a physician who's taking everything you've been talking about into account, what would be the goals? What would be the numbers, the T3s, the T4s, the TSH values, so that they could know that they were getting into the sweet spot, the appropriate place for normal thyroid function?
Well, I think the first thing that people need to know is to not accept your thyroid tests were normal as a result. You want to actually get a hard copy of your test results and go over them with your physician and be able to see the laboratory ranges and where you tested. A lot of the integrative physicians that are doing a lot of work with thyroid patients are now looking for optimal values rather than numbers that fall within the reference range. So general guidelines, and these don't apply to everyone because different people have different sweet spots, but generally the majority of the population tends to feel best when their TSH is below 2.0, when their free T4 is in the top half of the reference range at their laboratory, and when their free T3 is in at least the top half of the reference range, if not the top 75th percentile of the reference range. So those are considered the general optimal numbers. Now, when some patients are taking multiple hormones, they're taking a T4 and T3 hormone, they may have a little bit lower T4, but as long as their T3 levels are at the sweet spot and their symptoms are being relieved, the doctors are not typically going to worry about that T4 number. But that's generally the overview of sort of the target optimal numbers that the really forward-thinking integrative physicians are looking to get patients to see if they can really help resolve the symptoms and be fully treating the hypothyroidism, not just giving them enough medication to get into the normal range.
Tell us a little bit more about that treatment with T3 and T4, because I think the standard treatment has been, and perhaps continues to be, T4 alone, right? Levothyroxine, also known as Synthroid.
Well, and tell us what we mean when we hear T4 and T3 and where iodine fits into that.
Sure. Well, the thyroid gland's job is to produce these hormones, and iodine is the nutritional building block for thyroid hormone. So we need to have adequate amounts of iodine in our diet in order to properly produce thyroid hormone. The gland typically produces majority T4 and a little bit of T3, and the body then takes the T4 and converts the T4 by dropping one of the molecules of iodine into T3. So T4, sometimes I refer to T4 as the cake mix and T3 as the cake. T4 is a precursor. It is not useful in the body except in the ability to convert it into T3. T3 is the active hormone. It's what delivers the payload to those cells and glands and tissues and organs of energy and oxygen. So the T4 and T3 are two different hormones, and we're relying on the body to do the job of converting most of the T4 that we make into active T3 that the body can use.
So when a doctor prescribes the standard levothyroxine, also known as Synthroid, the brand name, what's being delivered to the body orally is T4.
Yes.
But the body then has to convert it from that T4, 4 iodines, to T3, 3 iodines on that hormone, and it's that conversion process that creates the active hormone.
Exactly. T4, levothyroxine, also, again, the brand name is Synthroid. Some people are on Levoxyl, levothyroid. There's Tirosint, which is a liquid capsule form of levothyroxine, but there's a number of different brands and generic levothyroxine, but it is a synthetic form of the T4 thyroid hormone, and the assumption then is that the body will convert that T4 that you're taking by medication into active T3 in the body that can deliver energy and oxygen.
Are there people who have trouble with that conversion?
Well, this is a controversial question because the standard dogma of the endocrinology world is that people don't have any problem and you will convert the T4 you need to the T3. But what we are finding is that there are some genetic defects, there are some nutritional issues or nutritional deficiencies, stress factors, other hormonal interferences, estrogen compounds in the body, overexposure to certain types of foods like soy that can impede the body's ability to convert T4 to T3 or get in the way of the body's cells' ability to take up the T3. So this is controversial because a lot of the endocrinology world thinks that some of this is not really established, but in the integrative world and in a lot of the research that we're looking at now that is looking at satisfaction with the different treatment protocols available, patients seem to need the addition of some T3 in some cases. Not all patients do. Some do fine on a T4-only protocol, but some of the research shows that the majority of patients actually prefer and feel better on a T4, T3 medication combination of some form.
Now, we have a number of listeners who are interested in natural approaches to treating their problems. Are there natural ways to treat hypothyroidism?
Well, it depends on what your definition is of natural, because there is a drug, a prescription drug, that is referred to as natural thyroid or natural desiccated thyroid. It is not a synthetic drug. It's an animal-based product. It's porcine or pig thyroid, the dried thyroid gland of pigs, and it's been processed to deliver a certain amount of T4 and T3. And that goes by the names Armour Thyroid, Thyroid. Those are some of the common brands. There's also some generics in the United States and IRFA from Canada. So this is the prescription natural, so to speak, drug. But in some cases, when people are asking about natural treatments, they're talking about a non-pharmaceutical or non-prescription drug approach to dealing with a problem. And in that case, what we're looking at is, for some people, not everyone, if you don't have a thyroid or your thyroid has been radiated with radioactive iodine, or you've had your thyroid surgically removed, or you were born with a small or defective thyroid or congenital hypothyroidism, you are going to need a prescription thyroid medication in order to survive. But for some people who have very mild or borderline thyroid problems, in some cases, testing for and identifying an iodine deficiency and then supplementing with iodine may nudge them back into an optimal range and feeling well. There's also a subset of people who develop Hashimoto's thyroiditis, the autoimmune condition, as a result of gluten and celiac sensitivity. And when gluten is completely removed from their diet, their antibodies revert back to normal, and their thyroid levels, in some cases, not all, can go back to normal. So it's considered a complete remission of their Hashimoto's and their hypothyroidism as a result of following a gluten-free diet. But that's not everyone with hypothyroidism. It's only those people who have a demonstrated gluten allergy or gluten sensitivity or full-out celiac disease.
Now, Mary, a couple of years ago, there was a formulation change in that natural thyroid drug you mentioned earlier. Could you tell us a little bit about the fallout and how some people have reacted?
Well, it's very difficult to pinpoint what is going on because the companies are not very forthcoming with the information. And in particular, I will call out the manufacturer of Armour has been kept things very close to the chest in terms of when they have reformulated and added or taken away fillers and other excipient ingredients. But the bottom line is that they've reformulated a number of different times, and in some of the cases, the reformulations, for reasons that we don't know because we don't always know what have they taken out, what have they put in, are causing patients to have malabsorption of the medication. So there were people whose TSH went from a very normal 1.5 level that they were maintaining on a same dose for years and all of a sudden shot up to 10 after the reformulation. There were people who had type 2 diabetes who were controlling their blood sugars beautifully, and after the reformulation, their TSH went up and their blood sugars went through the roof. So we had a lot of fallout from that. At that point, when Armour did reformulate, the folks at Thyroid ramped up their production, and they have been, in my opinion, more forthcoming about some of those formulation issues. They have not reformulated without announcing it to patients and things. So some of the patients ended up switching permanently away from Armour and going to either the generic, which seems to be a fairly consistent product, or going to the Thyroid product for better consistency. The key thing, I think, for patients is to monitor their own symptoms and to make sure that they're getting periodic blood tests, and anytime you get a medication refill, not just if it's Armour Thyroid, but even if it's Synthroid or one of the levothyroxines, you want to pay attention to any new symptoms that show up, because drugs, you can get an expired batch, you can get medications that have sat in the heat and have lost potency by mail order, or sat in a trunk, or sat in a car, or in a postal truck, et cetera. So we want to make sure that we're getting potent medication that's fresh as well, because that can also affect people fairly dramatically.
Mary, there are a couple of new approaches to low thyroid, and we might mention that hypothyroidism is one of the most common conditions in America today. I mean, tens of millions of people are suffering from this problem. Tell us a little bit about low-dose naloxone and autologous stem cells.
Sure. Well, low-dose naltrexone, also abbreviated as LDN, is a really exciting therapy for people with autoimmune-related thyroid issues, and it's also being used with a number of autoimmune diseases like MS and rheumatoid arthritis very successfully. And naltrexone at much higher doses is an opioid receptor blocker that's used for people with addiction. So it basically eliminates the brain chemistry pleasure of either narcotics or alcohol. So it's oftentimes used in conjunction with rehab programs or detox programs for people with addictions. But the researchers that were using this drug back in the 50s and 60s discovered that some of the patients went into remissions from their autoimmune diseases while they were undergoing treatment for addictions. And so they tested and discovered that they could take the dose of naltrexone down to very low levels. So a typical dose for addiction may be 80 milligrams a day. They're talking about 4 milligrams a day or even less, being able to modulate the immune system in certain ways, lower antibodies, and in some cases help patients achieve a remission or reduce substantially the amount and dosage of some of the drugs that they have to take to control their autoimmune conditions. It is an off-label use of naltrexone. That means the FDA has approved the drug for use in addiction. It has not approved it for use in autoimmune modulation, but it's legal for doctors to prescribe it. So the doctors that are working with it are those that are really knowledgeable about autoimmune disease and immune modulation, and it's very important to do it with a doctor's oversight because they may need to adjust medications that you're taking downward, especially for thyroid patients who may find that they need half the dose of their thyroid medication after several months on LDN.
Mary, I understand that the endocrinologists came out with guidelines for treatment of hypothyroidism in 2014. Can you tell us a little bit about that, please?
Yes. The American Thyroid Association and a task force of various top endocrinologists in the country got together and put together a new set of guidelines for the diagnosis and treatment of hypothyroidism. And while the endocrinology world was very satisfied with these guidelines, I can tell you as a patient advocate, the patient community and certainly the integrative and more forward-thinking physician community were really frustrated with these guidelines because the guidelines essentially are directing doctors to use only the TSH test as their gold standard test, and that the free T4 and free T3 and thyroid antibodies tests were not necessary for making a diagnosis, and that levothyroxine should be the only treatment offered to patients. And in fact, they even went so far as to say that use of natural thyroid or T3 as a supplement to a T4 therapy was so far out that they should be considering sanctioning those doctors under ethics violations for utilizing those treatment approaches. So it was really declaring war on a lot of the current thinking that the integrative and holistic community has found very effective in terms of diagnosing and treating thyroid patients. And, the interesting and concerning thing to me is that the task force was funded by the levothyroxine manufacturers. So it's not a surprise to me that the task force then turned around and recommended only levothyroxine, and in fact really pushed hard against natural thyroid or the addition of any T3 drugs to a treatment protocol. So I feel like it's a very controversial set of guidelines, and unfortunately, though, the guidelines drive a lot of insurance decisions, HMO treatment approaches, and so a lot of patients are finding it more difficult to get thorough thyroid evaluation and or treatment beyond just levothyroxine.
Mary, what advice do you have for our listeners who may have thyroid problems?
Well, my advice would be to learn as much as you can about the situation. Today, most of us with insurance or HMOs may have 5-6 minutes, if we're lucky, with a physician. And so we really need to have our homework done and be knowledgeable about what we want to ask for, to make sure that we know which tests we want and get copies of those medical records. And in some cases, if you really run up against a wall with your HMOs or your insurance-covered doctors, you may need to think about jumping out of your system and going to a cash practice, integrative type of physician who is not on any insurance plans or as part of any HMOs, because those doctors have more freedom to depart from these official guidelines and to be able to give you the full range of tests and the full range of treatment options.
Mary Showman, thank you so much for talking with us on the People's Pharmacy today.
It's been my pleasure.
You've been listening to Mary Showman. She's a patient advocate and the thyroid expert for About.com. She's written 13 books about hormones and thyroid health, including The Thyroid Diet Revolution. In addition to thyroid.about.com, you can find her at thyroid-info.com. There are links on our website.
After the break, we'll talk with scientist Antonio Bianco about why there's so much controversy over the treatment of hypothyroidism. Why do some people say they feel better on a combination of T4 and T3?
You're listening to the People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Squatty Potty, the original toilet footstool that creates healthy toilet posture. You can learn how squatting relaxes the colon and allows for easier and healthier elimination at squattypotty.com.
And by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. The number's 800-345-7339. The website is uttercream.com.
If you would like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1015. That number to call again, 800-732-2334, or place your order online at peoplespharmacy.com.
Today we're talking about hypothyroidism. New research may explain why some people do not feel well on the standard therapy. Our guest is Dr. Antonio Bianco, head of the Division of Endocrinology and Metabolism at Rush University Medical Center. Dr. Bianco also co-chaired an American Thyroid Association task force that updated the guidelines for treating hypothyroidism.
Welcome to the People's Pharmacy, Dr. Bianco.
Thank you. It's a pleasure to be here.
It is a pleasure to have you on the People's Pharmacy, Dr. Bianco. Let me just say that when it comes to hypothyroidism, and we'd ask you to please explain what that is, treatment is incredibly controversial and contentious, and we'd like you to tell us why.
Well, hypothyroidism is a clinical condition that is observed in patients when the thyroid decreases its production of thyroid hormone. Either decreases or it stops completely. So the thyroid produces hormones that are important for our body. Every tissue in our body responds to thyroid hormone. And obviously then when the thyroid doesn't work so well, so the production is decreased or even ceases to exist, the patients experience clinical symptoms. And therefore, treatment over the last 100 and 120 years has been to give back thyroid hormone to the patients. So started many years ago, 100 years ago, with patients taking slices of thyroids from animals in the breakfast in the morning, warmed up and just eating that. And obviously we evolved. Then the thyroid extracts were made. Thyroid extracts from animals were made in pills, and patients will take pills every day. And most recently, we have synthetic thyroid hormone, which is made by pharmaceutical companies. It's important that this synthetic thyroid hormone, although it's synthetic, is identical to the hormone that's produced by the thyroid, so that a patient with hypothyroidism will take a tablet every day, and this tablet contains the thyroid hormone, so that the system, the body, doesn't know the difference between the hormone that's coming from the tablet or the hormone that's coming from the thyroid.
Now, of course, that is where things get controversial and contentious.
Correct.
The synthetic thyroid you're referring to is called levothyroxine. It is known under the brand name Synthroid. There are also some generic names. Terry, I think you know what they are. Levothyroid,
Unithroid,
and
Levoxyl.
For the last 50 or 60 years, I think most medical students and residents in endocrinology are trained that all you have to do to solve a hypothyroid problem is give patients what's called levothyroxine, or T4. We'll ask you to explain what that is in a moment. And that the body will take care of the rest. And if you want to make sure everything is functioning perfectly, you just get a blood test and you measure something called TSH, thyroid stimulating hormone. Your new research suggests that maybe that's not enough for all patients.
Yeah. So what happens is that this T4, and it's called T4 because it contains 4 atoms of iodine in its molecule. It's actually a prohormone. T4 doesn't act in different tissues. It's a hormone that has a long half-life, stays in the circulation for many days. However, it does not trigger any biological effects in different tissues. In order to do that, T4 needs to be converted to T3. It needs to be activated in our body. And our body does that. T4 gets converted to T3 in different tissues. And in the circulation, patients that are taking only T4 will have plenty of T3 in the circulation. So T3 is the molecule that is responsible for the effects of the thyroid gland. So that if you say, well, what happens in the brain, what happens in the liver and skeletal muscle, it's T3. T3 is the molecule that's activating. But patients with hypothyroidism take T4. And then we hope and we wish that the body will just convert T4 to T3. And as you said, it is correct. In the last 40, 50 years, we've been taken for granted that just giving T4 or levothyroxine, how it's called, the pharmaceutical grade of T4, to patients, it's enough, because the body will, in its wisdom, produce or transform T4 to T3, will produce enough T3.
Now, the question that has been raised in the last, maybe 10 years or possibly even less, is really, do all people convert T4 easily to T3 in their tissues?
Right, that's correct. And in fact, yes, conversion of T4 to T3 exists in multiple tissues. And actually, I would say there is almost hardly you're going to find a tissue in our body that is not able or cannot convert to T4 to T3. However, I think the key question is, do patients with hypothyroidism that are treated with levothyroxine, do they have normal levels of T3, both in the circulation and inside the tissues? There's plenty of T3, but does it reach the normal levels? That's the key question. Because if we just ask the pituitary gland and we measure TSH, that's going to be focused mainly on T4 in the circulation. And how do we know about T3? So that we've been taking for granted, again, over this last 40, 50 years, that serum levels of T3 are normal. Now, most recently, some studies coming from Japan and from Europe have shown that looking at thousands of patients, have concluded that serum levels of T3 in patients that are treated with levothyroxine are actually slightly below normal. They're not normal. They're about 10, 20% below normal. So that has put a lot of people to think and say, well, is it clinically relevant to have serum levels of T3 that are slightly below normal range? The true question to this, the answer to this question is, we don't know. We have no data. There are no studies in which that specific question has been addressed. So, therefore, I think this is a major point of change in the approach of treatment of patients with hypothyroidism, because there are studies out there showing that serum T3 is below normal. And why is this important? Again, T3 is the hormone that triggers biological effects in the different tissues. So if a patient has a T3 level that is about 10, 20% below normal, the common sense will indicate that probably it's important. However, if you practice evidence-based medicine, we don't have the clinical study showing that this is in fact important.
Dr. Bianco, at the start of our conversation, you mentioned that there are symptoms of hypothyroidism. We didn't talk about what they are, but what we have heard from a number of people telling us about their experience with hypothyroidism and its treatment is people will say, I just don't feel good on T4 alone. If my doctor adds in some T3, I feel better. So the symptoms are not as apparent. And you and your colleagues have done some research, very recent, in rats that suggests maybe these people aren't making it up.
Correct. So what we know is that the treatment of hypothyroid patients with levothyroxine alone is effective in about 80% of all patients. So, in fact, the treatment with levothyroxine is highly effective. It takes care of 85%. The majority of the patients feel very well. And we know that because there are about 10 million Americans that have hypothyroidism. So we make 85%, 90% of these 10 million Americans pretty happy. However, there is a fraction of patients with hypothyroidism that are treated with levothyroxine alone that are unhappy. They remain symptomatic. Even though you're giving levothyroxine, you're normalizing serum TSH, they remain symptomatic. And it's interesting, they all have a very similar story to tell. They say, I remain unfocused. I remain tired, hard to concentrate. And now, the point that you made that this is somehow resolved by adding T3 to the treatment with levothyroxine, just adding a combination of levothyroxine to T3, it is correct. Many patients will tell you, I cannot live without T3. I need both T4 and T3. However, I have to say that there are about 22, 23 clinical trials that were performed all over the world, and the majority of these trials have not been able to document or to demonstrate scientifically that the combination of T4 and T3 is a superior form of treatment for patients with hypothyroidism.
Well, we have looked at the abstracts of some of those trials, and what we usually see is that the investigators write, well, we couldn't document that there was any difference, but there's a certain proportion of our patients who say they really like the combination and they feel better on it. It's certainly not all of them. It's not even the majority, but some of them do say, I like this better.
Absolutely, that's correct, and and it's been my experience, and most clinicians' experience as well. Some patients can't live without it. Why would that be? It seems that not all hypothyroid patients are the same, and that's one study that came out of the UK showing that a small fraction of patients with hypothyroidism, they exhibit what's called a genetic polymorphism in one of the enzymes that convert T4 to T3. That polymorphism is observed in about 15% of the population. And if you have that polymorphism, you're more likely to prefer a combination therapy. You're more likely to be successful with a combination therapy, including levothyroxine and T3.
Now, Dr. Bianco, you mentioned a small fraction. But if that small fraction is 10 to 15% of the population, we're talking over 1 million people in the United States alone.
Absolutely. I mean, no, it's a lot of people. No, the fraction is small. I mean, it's compared to 100%. But because hypothyroidism is so prevalent, absolutely, you're talking about a lot of patients, exactly.
Tell us about your research.
So we've been interested in answering these questions that we've been discussing so far. For example, is having a low serum T3 clinically relevant? Why we cannot normalize serum T3 with levothyroxine alone? And is there a fraction, or is it true that this polymorphism could in fact change the way we treat patients with hypothyroidism? And this is what we did with rats. We recently looked at combination therapy versus monotherapy to rats that had been thyroidectomized, so they were hypothyroid. And we saw that by giving levothyroxine alone, you could not, in fact, normalize serum T3. This is not news. Researchers in Spain about 20 years ago have shown the same thing. But what we've shown now is that the tissues remain hypothyroid, even when TSH is normal and serum levels of T4 are normalized. So the brain has signs of hypothyroidism. What are these signs? We measure the expression of genes that are responsive to thyroid hormone, and we saw that those genes, they exhibit a pattern that's compatible with hypothyroidism. We looked at the liver, we looked at the skeletal muscle. These are all tissues that respond to thyroid hormone, and they all exhibited signs and indications that they remain hypothyroid, even though, again, serum TSH and T4 levels were normalized. Serum T3 levels were slightly decreased, just like the situation we see in patients.
Dr. Bianco, what is the take-home message from your research and investigation into this whole issue of T4, T3 in patients with hypothyroidism that are not thriving?
Well, I think the take-home message is the majority of the patients do well with levothyroxine alone. 10-15% of the patients don't do well. And doctors need to listen to their patients. Doctors need to sympathize with their symptoms. And doctors, scientists need to look for alternatives, look for new forms of treatment. And it seems that the combination therapy is a valid form of treatment for the small percentage of patients. Some patients do very well. Other patients don't do well. Clinical studies have not been conclusive. And I think that it's because not all hypothyroid patients are the same. I think there are intrinsic differences in hypothyroid patients, and perhaps there are subpopulations of hypothyroid patients that respond very well to combination therapy, and other patients that don't respond at all to combination therapy. Our job as scientists and doctors is to identify these subpopulations with patients with hypothyroidism that respond to combination therapy and try to help them in that fashion. So I think that the take-home is that we still have work to do in that small population, subgroup of patients with hypothyroidism that respond to combination therapy.
Dr. Antonio Bianco, thank you so much for talking with us on the People's Pharmacy today.
My pleasure.
You've been listening to Dr. Antonio Bianco, head of the Division of Endocrinology and Metabolism at Rush University Medical Center. Dr. Bianco also co-chaired an American Thyroid Association task force that updated the guidelines for treating hypothyroidism. They were published in the journal Thyroid. You'll find links to his research articles from our website and an extended interview with our entire interview with Dr. Bianco.
Earlier in the show, we spoke with Mary Showman. She's a patient advocate and activist for thyroid and hormone health. Mary has been the thyroid expert for About.com since 1997, and she's written 13 books, including The Thyroid Diet Revolution. Learn more at her websites, thyroid.about.com and www.thyroid-info.com. You'll find links to them from peoplespharmacy.com.
When you go to the site, you'll also find an extended interview with Dr. Rita Aram, one of the leaders in combination therapy.
Lynn Siegel produced today's show. Al Wodarski engineered it. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1015. That number again, 800-732-2334, online at peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your own experience as well as your thoughts on today's show.
And when you visit our site, you can also sign up for our free newsletter or find our guide to thyroid hormones. It's all there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
I'm Terry Graydon. Thanks for listening. Join us again next week.
We hope you enjoyed this podcast of the People's Pharmacy.
If so, please leave a review on iTunes for a chance to get a free copy of our book, The People's Pharmacy Quick and Handy Home Remedies.
This giveaway is open to all U.S. residents at least 18 years old. To enter, leave a review on iTunes and send us a screenshot of your review on our Facebook page. The winner of the free copy of The People's Pharmacy Quick and Handy Home Remedies will be chosen at random on December 10th.
When it comes to Father's Day, dads want steak. And the experts at Omaha Steaks are making it easy for you to deliver uncompromising quality with gifts that are sure to make his day. Plus, get an extra $35 off with code THANKSDAD when you shop at omahasteaks.com today. But don't wait. Father's Day is June 15th. Shop now at omahasteaks.com and get an extra $35 off with code THANKSDAD. Minimum purchase may apply. See site for details.